And these are the thoughts that came to my mind. I'll just share it with you. Mistakes can be done right from the pre-operative state as well as the intraoperative and post-op. Okay?
Okay,
So, iatrogenic complications of anesthesia. So, the techniques mostly normally preferred for anesthesia can be classified into general anesthesia and regional anesthesia. And regional anesthesia is subdivided into central neuraxial blockade and peripheral nerve block. Do you agree?
yes, sir.
Yes. So general anesthesia can be IV sedation, IV monitored anesthesia care, or it may be a regular induction, intubation, and controlled ventilation with the drugs and the inhalation agents. So everything comes under general anesthesia, where patient is not aware of the surroundings. Whereas regional anesthesia, patient is awake and is aware of what is going on, but only the operative site is made to become numb. So this is the first thing that you have to know. And the iatrogenic complications can occur during the pre, intra, or post-op periods of any of these two techniques, whether general anesthesia or regional anesthesia. The iatrogenic complications can happen before the procedure, intraoperatively, or post-op period. Now, what are the pre-op complications that you can produce? Failure to see the patient in advance, that is not doing a proper pre-anesthetic evaluation because of laxity or urgency or negligence leading to improper evaluation of the patient. This is the first and foremost mistake that we do. We must always see the patient in advance, even if it is a trauma or emergency. We must make a quick examination. That is why the ample mnemonic is used, AMPLE. Do you know what is the expansion for ample, Muthupriya?
No, sir. No, sir.
It is given as a small clue or mnemonic to remember. A for allergies, M for medication, P for previous surgeries or incidents, L for last meal, E for emergency leading to the surgical indication. This is called the ample evaluation, AMPLE. A for allergy, M for medication, P for previous surgery or any untoward incidents, L for last meal, that is whether the patient is full stomach or not, and E for the emergency which has resulted in the need for surgery. So these are the 5 things that you have to ask, which is mainly meant for emergency cases or trauma cases, but it can be used in regular elective cases also. When the patient comes to the theater, you can, if you are not the anesthetist, somebody else has given the witness and you are going to start the case, you can ask these 5 questions and make sure that you are, because if you ask for the previous events, then the patient may say, last time I had intubation and they said it was very difficult, or I had sore throat after the intubation, or my tooth got knocked down. All this information you can get if you ask for the previous history. And so this is the first thing you have to think. So this can result in not knowing the patient comorbidities, their current status, medication history, allergies leading to complications in the intraoperative period. Then the next thing is failure to review the investigations in detail and missing some vital irregularity like anemia, leukocytosis, abnormal coagulation, elevated enzymes, PCG changes, etc., leading to problems in the intraoperative period. This again is part of the pre-op assessment. Lack of detailed airway examination leading to unanticipated difficult airway. This is the third most important iatrogenic problem. Failure to locate the venous access, especially in pediatric patients, children who are very chubby. I always insist the postgraduates to make sure during the pre-anesthetic assessment itself which vein is very nicely seen and mark it and tell the nurses not to damage that by trying to attempt starting the IV line in the ward. And that may lead to multiple attempts to secure the IV access. Failure to look for associated congenital anomalies, especially in pediatric cases, that will also lead to intraoperative problem. Failure to inquire about menstruation in female. Majority of the times, this is a very common mistake that is happening. So, childbearing age women, when they come for surgery, you must always ask, the surgeon usually should ask about the menstrual cycle and try to avoid surgery during that period. So menstruation in female leading to postmortem of surgery after all the preparations and done, things are done. So better to inquire about that also. And coming to pre-op complication continuation, failure to give proper pre-op instructions about investigations or medications or NPU advice, leading to intraoperative hypo or hyperglycemia, hypertension in hypertensive patients. You ask the patients to continue the antihypertensives. Only antihypertensive we avoid is, what is the antihypertensive you advocate not to take, Dr. Muthupriya? Which is the antihypertensive we usually stop before surgery.
AC inhibitors and ARBs.
AC inhibitor, very good. And so this instruction should be properly given. Otherwise, that may be the cause for the iatrogenic complication. Now, coming to intra-op complications, first we will see the complications due to general anesthesia. Their failure to do the machine check properly, oxygen supply source leading to catastrophic hypoxic insults, failure to select proper size mask, airway, laryngoscope blade and its function leading to delay or difficulty in securing the airway, improper technique of laryngoscopy leading to injury to lips, teeth, gum, tongue, pharynx and larynx, which usually happens during your learning period. Improper mask ventilation leading to distension of stomach, especially in pediatric patients. If you don't hold the mask and keep the neck in neutral position, invariably you will be causing the distension of the stomach, which may cause intraoperative as well as postoperative respiratory difficulty. And this may also lead to post-op vomiting and aspiration. And unnecessary usage of oxygen flush, which can lead to barotrauma. It's only machine concern. And failure to recognize esophageal or endobronchial intubation. And more than esophageal, endobronchial intubation is very common, especially during the learning period. You know, when you see the glottis, you are very enthusiastic and you push the tube beyond the carina and it goes into right or left main bronchus. Then patient will not go under, he will desaturate and then bag will become tight. So all these things can happen because of the wrong placement. And traumatic intubation leading to bleeding and aspiration of blood, especially when you do nasal intubation in ENT cases or in patients who are going to undergo cardiac surgery where CABG or open heart surgery where heparin will be used. The initial bleeding trauma that is caused to the airway can lead to bleeding which will get aspirated later on. And laryngo or bronchospasm due to instrumentation in an inadequately prepared patient. For example, a chronic smoker, if you have not asked him to stop smoking and given him some spirometry, and he has an irritable airway, this can produce. And if you are not given the proper plane of anesthesia in a reactive airway patient, that can also lead to these problems. And placement of IV access in a AV fistula limb or a BP cuff in the limb in patients with CKD who come with a AV fistula in the limb, upper limb, or if putting an IV line in the inaccessible site, that also can cause iatrogenic problems. And failure to select appropriate size cannula based on the anticipated blood and fluid loss, which may lead to difficulty in resuscitation later on. Just because the veins are all very small, you put in a 22 gauge needle cannula and there's sudden bleeding during lap cholecystectomy. The surgeon cuts the cystic artery and there is a profound bleeding. You cannot resuscitate that patient with the 22 gauge cannula. So you must assess what is the surgery and what is the likelihood of anticipated bleeding and select appropriate size cannula and place it in the correct vein so that you can resuscitate that. This is also an iatrogenic mistake. Wrong drug administration due to failure to label the syringes or administration of inadequate or excess dosage, especially in pediatric cases, by not properly diluting the drugs. Then over or underhydration leading to hemodynamic stability. Then failure to monitor blood sugar and electrolytes in patients with uncontrolled diabetes mellitus during emergency procedures especially. So you must always have a glucometer and try to keep the blood sugar below 200 intraoperatively by proper administration of quick-acting or short-acting insulin. Failure to monitor the temperature during GA leading to hypothermia and its consequences. And failure to monitor urine output leading to either fluid overload or dehydration and acute kidney injury. So that is also an iatrogenic complication. Then failure to provide eye protection leading to corneal exposure and ulceration. All these iatrogenic complications I am describing with regard to general anesthesia. And pressure injuries to nerve and soft tissue caused by improper positioning and not padding them properly. Failure to apply monitors properly at the beginning of surgery, leading to disruption of the signals leading to at the critical times of surgery and unable to rectify due to inadequate access. So whenever you place a pulse oximeter probe or a BP cuff or your ECG, it all should be properly placed with adequate access for that or secured correctly. Failure to take care of monitors and vascular lines during change of position, especially during prone position after induction of anesthesia, leading to disconnection and bleeding. Failure to inform the surgeon in time during development of unanticipated complications like malignant hyperthermia or thyroid crisis or air embolism or anaphylaxis. This is also considered as an iatrogenic problem. And inadequate analgesia leading to intrapachycardia hypertension causing CVS or CNS complication. Failure to assess muscle paralysis during usage of non-repotracing blockers leading to bucking and coughing on EP tube, especially during neurosurgical procedures, which may lead to catastrophic increases in intracranial pressure. Failure to provide adequate depth of anesthesia, resulting in awareness under anesthesia with associated problems of unpleasant memories and post-traumatic stress disorder. Now, coming to the post-op complications after general anesthesia, failure to take steps to prevent vomiting and regurgitation during recovery, which is one of the important things which will lead to aspiration. Failure to assess return of adequate muscle power after resusc and hasty extubation, which may result in either a patient having inadequate ventilation and hypoxemia or stridor and laryngospasm. Failure to provide adequate analgesia leading to restless and violent recovery, which you must have experienced. Failure to prevent shivering due to inadequate measures taken during intraoperative period. Failure to identify cause of patient restlessness due to full bladder or catheter irritation after PURP, and all patients who are likely to be catheterized should be informed before induction of general anesthesia that they will have a feeling to pass urine because of the presence of the catheter, and then they will understand and they will be able to cooperate. If you are not told, you may have severe problem because of the catheter irritation. And proper steps to be followed during shifting of the patient, especially obese ones, to prevent the fall from the OT or the stretcher. Now coming to the second part of anesthesia, that is central neuraxial block complications. Failure to position the patient properly for the spinal, especially leading to multiple attempts, which she mentioned. Failure to ask for help. If you are not able to secure the subarachnoid block within 3 or 4 months, don't keep on trying. Ask somebody else to do that and don't hesitate to ask for help to prevent discomfort of the patient. Inadequate pre or co-loading leading to acute hypotension after subarachnoid block. So make sure the patient is adequately hydrated. Not keeping emergency drugs loaded ready, leading to delay in resuscitation after a severe fall in BP. Failure to prevent intra-op shivering by pharmacological or non-pharmacological methods, especially after spinal. And PDPH due to use of large size needles or accidental dural puncture during epidural anesthesia, which is considered iatrogenic. And failure to inform the patient about noise pollution due to surgical instruments. So, Miot students, you will all be very aware that surgical instruments, the drill and other things used by the orthosurgeons produce a lot of noise. So, patient must be told in advance that because he is awake after a sensory axial blockade, you may be hearing some sounds, but don't get worried about it. So, you must be reassured about that. Failure to protect the patient from radiation hazards, using of C-arm and X-ray. Failure to protect patients from electrical burn injuries due to improper placement or cooling of antiseptic liquids to prepare skin. Failure to prevent the patient from watching the surgery by reflection in OT lamps, leading to apprehension and fear. So their eyes should always be kept closed, or a proper screen should be applied so that they don't watch the reflection from the overhead lights. Failure to avoid unnecessary conversation, creating sense of insecurity in patients. So cutting jokes or laughing loudly, all these things should be avoided when the patient is under. This can produce a lot of psychological stress on the patient. And lastly, coming to the peripheral nerve or plexus block, failure to follow proper aseptic precautions with chances of infection. Failure to calculate correct dosage based on body weight, leading to toxic dosage or local anesthetic toxicity. Failure to avoid recognize intravascular or intraneural injection, which may lead to toxicity. Failure to monitor vitals when you are performing the block. So always put on the pulse oximeter at least during the performance of block so that you can immediately notice any change that is happening. And failure to keep the emergency drugs and equipment ready for anaphylaxis as well as local anesthetic toxicity. Performing the block on the wrong side. Using the catheter which is inserted for continuous analgesia wrongly for infusing IV fluids like saline or interlactate. This has happened especially when you put in a supraclavicular block continuous catheter. This mistake has happened several times in Stanley hand injury department. So specifically we write on the plaster, do not connect IV drips to this. So we specifically make a note to avoid the complication. So I think these are all the iatrogenic complications which I can think of, which commonly happens. And if you classify them like this and try to answer this, I think that will make a good presentation. All of you agree with that? Okay, Priya?
Yes, sir.
Okay.